Hi, everyone. I want to welcome you back to the course and just say that we really have a great session today. I wanted to just quickly put today's session in the context of the course so far. As you know, we've centered attention on big theories and orientations to trying to understand this pandemic. We've looked at history, literature, other perspectives from the humanities and the social sciences. But the course takes a turn here today to really begin to develop a much closer look at the pandemic itself. And as Ingrid and I explained to you at the beginning, we're relying on Harvard faculty to present the issues that are critical to understanding the pandemic. And today's speakers are all people who have worked deeply in the field of epidemiology, epidemic modeling, statistics, and thinking about epidemics and diseases. But all three of them turn their attention, as one might expect, but doesn't always happen, to thinking through COVID now, using the methods and strategies and innovative techniques that they utilize. So it makes me very excited about today's session because we have three guests who are really deeply involved in trying to understand the epidemic and to impact outcomes for public good. So before we start, and Ingrid introduces our speakers, we have a quick poll, and it asks you to do some epidemiological modeling or prediction about where you think the pandemic is heading right now. So Ivan, if you could put up the poll, we'll see if students' assessment of where the epidemic is heading are consistent with today's experts.
There we go.
Interesting, you know, obviously a majority of you think there will be more than 250,000 deaths and perhaps, you know, less than 400,000, but it's a very interesting finding. And the other question, Ivan?
So I'll just make a comment at this stage. There was a really interesting thing that was done early on in the pandemic when a lot of people, including me, and I think some of the other people on here, were Nick Reich kind of convened a group of people to say what they thought was going on and a bunch of questions on a regular basis. And it was a very, very good exercise. The difficulty with it, though, is knowing exactly what the question is. Because is it the number of deaths or the number of deaths that will be reported? Because of the fact that that's not necessarily the same thing. If you look at the excess deaths in the United States in this year to date, even a pretty conservative estimate puts it at around 230,000, which is, you know, higher than the actual official confirmed cases or confirmed death counts. So, you know, sorry to make it more complicated, but it's the way it is.
No, actually, we're hopeful that you'll make it more complicated. And I think that, you know, you've already raised a critical question, you know, how do we count? What can we count? Where are those counts most accurate? Where are they more limited? And obviously, these are questions we want to explore today. So those are our crude guesses. You know, I have to say, as a historian, one of the issues that came up right away for historians is how big will this be? How does it compare to other big pandemics? And overall, I've been frustrated with that question because the dimensions of the pandemic are obviously crucial to all of us, but there are many more issues about how disruptive a pandemic is, what its impact is on health in the long term, how it persists. So, you know, I often get asked, how do pandemics end? And we would ask a question like, well, HIV pandemic isn't really thought of in this emergent crisis way now, but we know it persists in very large numbers and creates massive suffering. So how do we make comparisons is one of the questions that, of course, you do in your fields of epidemiology, but is also done using other strategies as well. So let me turn it over to Ingrid, and really looking forward to these talks.
Thanks so much, Alan, and thank you so much to our speakers. We are thrilled to have this amazing group with us today. As Alan mentioned, these are really three of the leading experts who have emerged in the COVID pandemic in the field of epidemiology and modeling. They represent just a small sampling of the tremendous expertise we have here at Harvard, and we're so thrilled to have them here today. I know they're going to share their thoughts with all of us as we move through this. So I'll just do a brief introduction of all three, and then I'll pass the torch on. And as usual, we'll save our big Q&A for the end. Our first speaker is going to be Professor Majumder, who is a computational epidemiologist. And it might be helpful for some people to have an explanation of what a computational epidemiologist does. She is on the faculty of the Computational Health Informatics program at Boston Children's. And she has really specialized in emerging epidemics and has had a focus on probabilistic modeling, artificial intelligence, and systems epi in the context of public health. And most importantly in this conversation, she was one of the first people to really study the transmissibility of the novel coronavirus strain when it was identified in China, and using publicly available data, which is really interesting, and phenomenological modeling to really characterize the transmissibility. So we're super excited to hear from her today about that topic and any others she wants to expand upon. Our second speaker will be Professor William Hanage, who is an epidemiologist based at the T.H. Chan School. He uses a mix of theoretical and lab work to research the evolution and epidemiology of infectious diseases. And his earlier focus was on the H1N1 pandemic and the pandemic potential of viruses, and is now using that understanding to inform his groundbreaking work on COVID. And we're thrilled to hear about his perspective and the work that he's currently doing. And then our last speaker is Professor Caroline Buckee, who is also an epidemiologist at the T.H. Chan School, and she's the Associate Director for the Center for Communicable Disease Dynamics at the Chan School. And if you've been watching the news at all, you've seen that that group has just been at the forefront of sharing information about models as they've moved forward in this moment. And she's really been a leader in using mathematical modeling and data science to help understand the mechanisms that drive the spread of COVID. And so these are going to be three very critical and significant conversations. I'm really excited to hear from our speakers, and we'll look forward to having our Q&A afterwards. And just a friendly reminder to people, you can put your questions into the Q&A at any time, and we'll make sure that we try to leave sufficient time to ask as many questions as we can. Thank you all so much. I'll hand it over to Professor Majumder.
Okay, great. Let me try to share my screen. Let's see here. Let's see here. Okay, fabulous. All right. Okay. All right, everyone. Really happy to be here. As Ingrid just introduced me, I'm Majumder, and I'm going to be taking a little bit of time today to talk about my group's COVID-19 related work in the field of computational epidemiology. So before we jump in too deep, I'll give a very brief introduction as to what computational epi actually is. So in the field of epidemiology, there are lots of different areas that each of us focus on. And And computational epi is somewhat of a new area where we use diverse data sources to get a better understanding of epidemiology in a lot of different contexts. So today I'll be talking about some of my work with things like search query data and human mobility data and that sort of thing. And this kind of falls within the broader context of computational epidemiology. So just to provide some quick context, especially because I'm the first person going today, I think all of us know that there have been almost 30 million reported cases worldwide. Bill mentioned this really important piece of all of this, which is this is reported cases. This also applies to reported deaths. And what we know is that this is only a fraction of total infections, or in the case of deaths, only a fraction of total deaths. And part of that is because of lack of testing. Other issues that really have been problematic over the last couple of months involve the varied I guess, interpretations of what does and does not constitute a COVID-19 case, especially given that many folks have really mild illness. So this is the kind of context that we're in right now. We know that there are this many cases that have been reported worldwide, but we also know that they're only a fraction of the actual number of infections or the actual total burden associated with this disease. So my group began conducting research on the January 20. This is when sustained human-to-human transmission was first suspected. So our earliest work, which was mentioned during my intro, hinged on assessing the transmissibility potential associated with COVID-19. And that's shown on the right here, as well as the citation at the bottom of the screen. And it was really interesting early on trying to use what little data were available to try to figure out what was the transmissibility potential, or the basic reproduction number associated with this disease. So the basic reproduction number is often defined as the average number of cases each index case will cause in a fully susceptible population. And what's really important about this number is that it's very context dependent. So it depends a lot on where you are, what the current state of the population is, so on and so forth. And it's related to another quantity that's really important, which is the effective reproduction number. And that's something that a number of my colleagues have been researching lately, and that looks into how transmissibility is changing over time. So early on in a pandemic, we care a lot about this number, the basic reproduction number, because we want to understand just whether or not this new pathogen can create potentially a pandemic or an epidemic or something of that kind. And so early on, we got a sense that, yes, this coronavirus looked like it did have a pretty serious potential for transmission across human populations. And unfortunately, that has apparently been true over the last several months. Today, however, I'm actually going to be covering some of my more recent work with my group because I think that it adds a somewhat different take on a lot of the different modeling activities that have been going on. And I'll be covering kind of very broadly agent-based models for disease transmission, principal component and latent derelict analysis of bibliometric data, and news media and search query data for event-specific surveillance. And I'll try to go through each of these at somewhat of a high level and take questions later on for any more detailed understanding of each of these papers that I'll be covering. So the first paper I'll be discussing considers my team's investigation of COVID-19 dynamics in 3 different locations: Hubei, China, which is where this pandemic originated, Lombardy, Italy, and New York City, New York. So I think any of us that have been following the news are aware that these 3 locations have been really important throughout the course of the pandemic. We've learned a lot of different knowledge about this disease from these 3 locations. And one of the things that is really interesting about this work, in my opinion, is that it uses agent-based models for disease transmission. So what is an agent-based model? So agent-based models, or ABMs, allow us to simulate real-world populations by assigning predefined characteristics to each agent based off of existing data on the population of interest. So that includes things like region-specific contact matrices, meaning how many contacts a day do individual people have, household structure, age distribution, distributions, comorbidities, and a whole host of other things that make populations unique from each other. So in our paper, we built a population-specific model for each of our 3 locations, and each of those locations involves millions of agents across those locations. So this was a pretty computationally hefty project. But after defining the characteristics for each of our agents, we repeatedly simulated their progress through a susceptible, exposed, infectious, and removed, or SEIR style epidemic model, which is what's shown here. And by adjusting the contact matrix, which is highlighted here in green, for each of our 3 populations, we're also able to test how different policy interventions, such as sheltering in place by different age groups, might impact the simulated epidemics. So what we ended up finding was that sheltering in place by a single age group had the potential to produce a protective effect against transmission for the entire population. But which age group had the greatest impact varied across our 3 locations, which again emphasizes just how important it is to think about context when we think about transmissibility of a given infectious disease. So this work suggests that partial population sheltering rather than universal lockdowns may be a creative solution for reducing COVID-19 transmission in the months ahead. But that recommendation really depends on, what the population is. So who we should be advising to shelter remains very much population specific and context specific, as I mentioned before. So the second paper that I'll be very briefly discussing considers my team's investigation of the rapidly growing scientific literature regarding COVID-19, which I'm sure that, in this class we've probably touched on a little bit already. One of the really unique aspects of this pandemic is just how quickly scientific information of all kinds has been generated. So one of the things that we wanted to look at was whether or not we could use different types of natural language processing techniques and machine learning techniques to understand what exactly was the content that was being produced by all of these scientific papers. And so we ended up using these 2 techniques, principal component analysis and latent Dirichlet analysis, to really try to understand what was going on in the body of literature that had been produced so far for COVID-19. So we used PCA and LDA to analyze tens of thousands of different scientific abstracts related to COVID-19, as well as 2 other related coronavirus diseases, MERS and SARS. And so PCA helped us identify large-scale trends in COVID-19 research and their divergence away from MERS and SARS research. So as is shown at the bottom here on the slide, lemmatized key terms across abstracts suggest that words like patient and case are thus far overrepresented in the COVID-19 literature, whereas words like protein and cell are underrepresented in the COVID-19 literature. Then digging deeper via temporal LDA, which is what we use for topic modeling in our paper, we were able to determine that laboratory-based study, including basic microbiological research, has thus far been lagging in comparison to non-lab studies involving the public health components of COVID-19. So this is important because we know that there have been marked federal funding cuts to lab-based research programs across the country, and our work suggests that this kind of research may be under-resourced and should be prioritized as the pandemic progresses. So the last paper that I'll discuss very quickly before handing things off is, in my opinion, a kind of interesting combination of computational epi, scientific communication, and also the study of misinformation and disinformation during the period of COVID that we're currently in. So this involves my team's investigation of the general population's response to President Trump's April 23rd remarks regarding the off-label use of disinfectants to treat COVID-19. So the bottom of the slide shows temporal trends in Google search fractions for 4 topics, which are defined at the top of the slide: purchasing disinfectants, drinking disinfectants, injecting disinfectants, and poison control. As is clear from the line chart, all 4 topics peaked after President Trump's remarks, and noticeably, poison control peaked a day after the other 3 topics, which is, of course, quite concerning. To account for the fact that the general public may have simply been interested in Trump's remarks regarding disinfectants rather than in the actual off-label use of them, we used each of the 4 topical queries with the term Trump appended to them and plotted the resulting data as well. As shown in the first figure, queries without the term Trump were still considerably more popular than those with it within the body of search query data that we're looking at. Then similarly, to account for the fact that news coverage of President Trump's remarks may have driven search interest in the aforementioned 4 topics, we minimized media bias using an autoregression-based approach that is outlined at length in the paper. And this particular paper is coming out soon, but it's also available as a preprint for those in the audience that might be a little bit more statistically minded and are interested in this debiasing approach. But this debiasing approach resulted in slight blunting of the observed peaks, which is understandable because, of course, some people certainly searched for these topics because they were interested in the news associated with Trump's remarks. But what we also notice is that the blunting is negligible with respect to the overarching trends. Though we can't infer causation from this work, the fact that internet search interest in poison control centers peaked after queries regarding off-label use of disinfectants suggests that search query data could be used as an early warning surveillance system for poison control centers in the future. And this need might be increasingly dire as false cures for COVID-19 continue to be propagated by those in positions of power. So with that, I'll call it a wrap and hand off the mic to our next speaker. Thanks everybody for listening, and I will be very happy to take questions at the end of the session.
Thank you so much. That is a fascinating tour de force. Obviously, there's not enough time to go into all the details in that conversation, but we'll get wrap back around to Q&A. And just the use of publicly available data with some of the AI technology is fascinating. So we'll look forward to following up with a few more questions. I will pass it on now to Professor Hanage.
Making sure I'm unmuted.
You're good.
Are you able to see my desktop? Yes?
All good.
Cool. Okay, so I'm going to be talking very, very, very generally indeed about a bunch of the things that I was specifically asked to, because I was given a couple of questions to specifically cover a couple of issues to do with modeling and epidemiology. And so I've just put together a few slides in order to illustrate it. The first thing is what Ingrid was saying, which we were introducing, which is kind of like, this is not the first pandemic, quite far from it. It certainly won't be the last one. So, the previous one, which was you probably heard of and thought about, is 2009 and swine flu, H1N1. And this is a piece of work that I was involved in then, back when I was at the time at Imperial College. And my major contribution to this was just looking at that thing on the left, which is it's a phylogenetic tree, which is made from one of the genes in influenza. I remember looking at this and kind of thinking, whoa, there's more mutations down than I would expect. And you can actually use these trees in order to estimate changes in growth rates over time, because that will depend. Every time you see these little things join, that's the thing which is, indicates that they have a common ancestor. And the probability of two things picked at random having a common ancestor is related to the population size. Obviously, it's more likely when the population is smaller. And so we use this with varying amounts of data. The blue is later on in the pandemic, in order to estimate the reproductive number, which is what we were just hearing about. And it's actually remarkably good. I've just noticed incidentally that my name in this is right next to Maria's, who is now obviously very key in the WHO. And this is a comparison with the results from a more conventional epidemiological analysis, and you can actually see that they are pretty similar. It's kind of remarkable that we were able to do this. And we were able to do this within a matter of weeks after the outbreak was recognized. And this was actually one of the things which went into WHO deciding to say that was a pandemic, which it was. It was much less severe than the current one. However, it was a pandemic in the sense that it did go all around the world, and a large number of people died, just not as large a number as we're going to be seeing with COVID-19. Now, one of the things which is interesting about comparing flu with SARS-CoV-2, SARS-CoV-2 does not mutate at anything like the same rate as influenza does. It actually has an element of error correction. So even though it's got a big genome, we haven't been able to do this kind of thing, not as quickly at any rate. However, as time has gone on and variation has accumulated, indeed, we've been able to see, I've been involved in a little work with the Broad Institute in which we've been estimating the time which the virus was introduced to Massachusetts. And we can do that. And again, it has sort of come into line with the expectations we'd have for more conventional epidemiological analyses. However, one thing that I think you all have to remember is that we're playing this game at the moment. I don't know if you'll remember, there was there were these books when I was a kid called Choose Your Own Adventure. Right now, we're kind of living through a thing of choose your own pandemic, because what we see depends on the interventions that we have taken. So for instance, early on, WHO said that there was lots of household transmission and emphasized that after the joint mission to China. But there was, because people were confined to their households. That does not necessarily tell you anything very much about what will happen if people are circulating in a more normal fashion. I don't know if Caroline may say something about mobility, but mobility and contact rates are incredibly important. I was also asked to say, what are my top 3 things when evaluating a model? They're really all the same things, as what are the assumptions, what are the assumptions, and what are the assumptions. Tony Fauci said this. Back in the spring, I spent about an hour sat in this chair in front of this laptop, preparing to go on television and explain things about models after the White House press briefing. And eventually they pulled me because the press briefing had gone over time. And I said, well, that's okay. And there's nothing better I could be doing, is there? And the producer just commented, yeah, it's been happening a lot. Sorry. So anyway, but Tony Fauci said in that, he said, I'm sorry about my modeling colleagues, but the most important, they're only as good as their assumptions. And that's true. It's absolutely true. And give an example. We were just hearing about agent-based models, which are phenomenally cool. I remember seeing an agent-based model being presented, which had been parameterized with extraordinarily good data about people moving around in a city. It included everything down to the level of dog walking. And they released something a bit like flu onto it and looked at how rapidly it transmitted. And then the question was, well, what do masks do? And they say, we assume these people wear masks and that masks prevent transmission by this amount. And then they ran it again and the epidemic curve was different. And they said, this shows that masks can prevent transmission. Well, and that's not the conclusion of the model. That's one of the assumptions. So it is not good enough to be able to do that. So I always look at what the assumptions are. I always look to see whether or not they fit with my understanding of the parameters and what's actually going on with the infectious disease. You learn about that by studying a lot of infectious diseases. That's how you do it. You learn in peacetime from what you're going to be doing in wartime. And now I also tend to look at these sort of things and say, are any of the parameters which have gone in, which are the precise numbers which go in suspiciously precise? Because if a key parameter has been defined as being 4.237, you have a right to ask, what would happen if it was 4.238? And that's the thing which that's a sensitivity analysis, which is when you put in things, you try and break the model and see how robust your conclusions are. Now, the next thing I'm going to ask to talk about are the role of some of the things we don't know. And these are things that right now, because in fact, as we just heard, there's been a phenomenal amount of extraordinarily good science which has been come out of this, and very rapidly, but still there are stubbornly some things we don't know. One of them is exactly how much aerosol transmission goes on. Now, again, we're playing choose your own pandemics, so the opportunities for aerosol transmission, which means transmission which occurs by teeny tiny particles called droplet nuclei, which can happen over a longer distance than the droplets, which are usually considered to be important in spread. Exactly how much aerosol transmission goes on is not clear. Now, I think it's clear, it is true that it can happen, but just saying something that can happen doesn't mean that it is important. Doesn't mean it happens enough that it is driving things. It could be, I'm fond of pointing out, as you can see behind me, that side, I'm a fan of Arsenal Football Club. Now, if Arsenal Football Club, that's a soccer club in North London, they can beat Liverpool because they have done it. But if they do it once, it doesn't matter because they have to play that well over the entirety of the season to make a difference to their final league position. In the same way, even if aerosol transmission can happen, it doesn't mean it's necessarily driving the pandemic. And that's a question which is still currently open. We're still trying to pin down. Children, everybody is very concerned about children at the moment. They definitely present differently. They are much less likely to have symptoms, but that doesn't mean they cannot transmit. Just last week, we saw an MMWR report about outbreaks in Utah in childcare centers. Now, again, I want to caveat that by saying that those are 3 childcare centers where outbreaks were observed. How many outbreaks were not observed? And how many childcare centers were there in which an outbreak did not happen? So you have to consider all of these things. And then additionally, we have the open question about how much transmission masks actually prevent. I think it's clear to say some. I think it's clear to say that masks are a key part of any public health response. However, exactly how much is done and how many people need to be wearing them in order to have the beneficial effects, those are open questions. And they have interesting non-linear kind of implications depending on your assumptions. See, I said assumption again, about the degree of transmission which is prevented and the types of masks which are being used. And then finally, I was asked to comment on herd immunity. Herd immunity is what happens when the proportion of the population that is immune is sufficient that it starts to slow the spread of the infection to such that the effective reproductive number is less than 1. That means that on average, each person who is infected will infect less than one other person. So this is a very, very idealized, somewhat artificial epidemic curve, which is looking at that reproductive number, which starts off at 2, and at this point passes through 1. So at 1, that's the peak incidence. That's the point when the new infections reach their peak, and after that they start to decline. Prevalence continues to go up because people don't get infected and recover immediately. But then it starts to drop. And this happens in this case for a thing where we have an idealized, completely naively mixing population. This happens when 50% of the population are infected. But note that, it still keeps going on after that. So when you hear people talking about herd immunity, and that as being a desirable thing, note that the point at which that happens is not the point at which it's over. People will continue to be infected. You have all of that down curve to go through as well if you approach it in an uncontrolled fashion. And I will leave you there, and I will, as I said, ask me why later about some of these things, and I'll be very happy to take questions at some point.
Thank you so much, Professor Hanage. That is, again, fascinating. And the role of modeling, I think we'll get to this in the Q&A, has been critical to informing so many of the decisions that need to be made in the context of this pandemic. So we will look forward to having further discussions, but that was incredibly thoughtful and another tour de force. I will pass it over to Professor Buckee for our final speaker.
Thank you. So I'm going to maybe take it a step even further back and start with these epidemic curves. This is data from the New York Times showing the cases in the US. Here's the cases in the top and the deaths in the bottom. And we've all been looking at these curves for a while. And of course, the deaths lag the cases in time, and I want to talk about that. But the other thing that's really important here when we think about modeling and the role of fitting epidemic curves to this kind of data is what is the unit that you're considering in spatial terms, right? So this epidemic curve is actually the result of multiple local epidemics that have been happening staggered in time and in different places. So the start of the epidemic, this just shows these different states, and this is over time this year. And so, of course, we started out with this epidemic being imported from China, and then we had outbreaks in New York and Massachusetts and Seattle and so on. And then over time, it's moved to the South. And so in a sense, we have to consider these as piecemeal epidemics that are happening locally as the disease spreads through the country. So the first thing to say when we think about how we model the epidemic, or how we even think about these forecasts that you might be seeing, is what is the spatial scale that we're considering this on? Is the national scale appropriate? In the US, probably not. We don't act as one population. So I'm going to take us back to the very basics of modeling, okay? And this is the classic SIR model. And the thing I want to point out here, as Bill said, what are the assumptions? Even if you move to a very complicated agent-based model, underlying the transitions that individuals take in your model, it usually comes back to some version of this, the SI. In the case of coronavirus, there's an E, which is an additional period before you become infectious. But generally speaking, this is what we're working with, no matter how complicated the model, no matter what kind of model it is, assuming it's not a statistical model, but if it has mechanism in it, these are the underlying assumptions. And so it's important to just walk through exactly what these are. individuals in your model start off susceptible, become infected, and then recover. Now, right now, of course, we don't know really much about immunity. That remains a very big unknown for us. But the dynamics of the model depend on some of these simple parameters. The probability of infectious contact, so that is the likelihood that an infectious person and a susceptible person come into the same space where they can breathe each other or cough each other or whatever. The probability of transmission given that contact, right? So as Bill was saying, you know, how often are you actually transmitting virus to somebody in your household, even if you do have close contact with them? And then the recovery rate. So of course, the rate at which new people become infected depend on how many people have the infection. And that will be reduced depending on how quickly people recover. So all in all, we've been talking about the reproduction number under this very simple framework. And again, these other models you've seen are sort of an elaboration of this. It really comes down to these three parameters, which is, you know, the probability of contact, the probability of transmission given contact, and then inversely proportional to the recovery rate, which determines how many people are going to be infectious. And we retrieve these kinds of very simple dynamics that Bill showed before. Now, some general findings of these kinds of SIR models is twofold with respect to those curves that I showed in the beginning. There are two ways that epidemics go away, as it were. The first is that the virus completely is eliminated from the population, so it's just no longer circulating anymore. The second is that susceptible people run out, and that's assuming that nothing else about the model changes. Now, what we've seen in the US and around the world is an unprecedented behavioral change that impacts K, this parameter that determines the rate at which people who are susceptible and infectious come into contact. We've artificially changed K through our non-pharmaceutical interventions, through our lockdowns. That's the whole point of them. And so instead of the epidemic dying out as it would in a sort of normal hypothetical model, because susceptible people have run out, instead it started to go away because of the interventions we put into place. And this has been a misunderstanding right from the beginning, that the epidemic's going away because it's following dynamics as in these classical SIR models where susceptibles run out. That's not the case now, because we've changed our behavior, we've changed K, we've flattened the curve, as it were. And so there's no reason that we've run out of susceptibles, because we likely haven't reached herd immunity in many, many populations. So this issue of herd protection, right? So here we have a reproductive number of 4 in this idealized population. And so each new infection leads to 4 new infections, and they lead to 4 more. And so you get exponential growth. The idea is that if some fraction of these are immune, then you might still get sputtering transmission chains, but you're not going to get the epidemic growing with a rate with R naught above 1. And that determines a general principle that relates the reproduction number to how many people you need to vaccinate to stop an epidemic from happening. And this is a debate that's going on right now for coronavirus. And the reality is that we don't really understand the contact patterns or how our interventions have impacted the contact patterns well enough to make definitive statements that generalize. Contact rates are very context specific, which means that the reproduction number is also going to be context specific and depend on the location in question. So it's not a fixed value, because K, this contact rate, is also not a fixed value, and it depends on our behaviors. What we do find as a general rule is that the extent to which epidemics can take off depend on things like the population size and population density. And that's another general finding of these SIR type models, which is why we might expect to see different types of behavior in cities versus rural areas. And indeed, we've seen that in the US as well as internationally. So I want to bring your attention to the curves that we've seen for other settings, right, around the world. So you might have seen these types of graphs where we're looking at different countries and how their epidemics are going. And similarly, a lot of this depends on the extent to which countries are testing. So just to go back, we look at these epidemic curves, and the tendency is to look at them and assume that they are somehow reliable. The fact is that testing rates are so variable in time, in space, and who even gets tested has changed over the course of the epidemic, such that it's very hard to actually rely on these data to make sense of where we are, let alone parameterize models. So one of the problems, so I agree with Bill that, what are the assumptions, what are the assumptions, what are the assumptions, but also what data are you using to parameterize your model fits? So where you think we are in the epidemic and what you predict might happen next in your mechanistic model is very strongly dependent on how you assume the cases are being recorded and whether you think we have captured them effectively. And that is a huge uncertainty that is very difficult to get around regardless of your model structure. So I will just say a few things about what we've been doing to try to understand transmission, these contact patterns that are underlying what's happening with the dynamic of the epidemic locally. So if you think about a person who gets infected here and then they have an incubation period where they're not symptomatic yet. They get symptoms, they get tested, a few days later they get test positive, perhaps they're hospitalized. In the interim, they may be infecting people. So we have, as I said, this unreliable indicator of confirmed cases that we can measure. It's lagged in relation to the actual transmission event that led to that case. We have hospitalizations and deaths, but they are also lagged by several weeks at that point, right? So what we really want is an indicator of the transmission, the contacts that are leading to transmission in real time. So there are two kinds of spatial aspects to these types of contact rates. There's of course transmission within populations, the local contact patterns that that spread the virus. And then there's importation, so movements between places that import infections. And of course, we're very concerned with that with colleges reopening and all the students coming back from places with different levels of transmission and what that means for importation. Something that we've been doing is working with mobile phone data from mobile operators and Facebook and other things like that to try to measure the types of contact patterns, at least on a population level, that might be driving transmission as an indicator, as an early warning for what's happening with the epidemic. That's my graduate student. And all I want to point out is that there's behavioral aspects to this that are interesting. First of all, the entire US basically stopped moving in mid-March, regardless of the local policy. So people's behaviors may or may not relate to the policies that are put in place. And indeed, in the US, we basically saw the entire country change behavior in mid-March, and then we've subsequently seen movement patterns increase since then. I'm not going to go into this, except to say that we have very different dynamics in commercial versus residential districts. We've seen an emptying out of cities. This shows the nighttime Facebook population, which essentially is how many people are resident in that place. And you can see that we've seen a massive depletion of the population. And that has a big impact because it changes the contact rates, it changes the density of the population, it changes the forecast of your models. This is New York, and you can see Manhattan is emptied out. So it's very heterogeneous, and it's dictated by things like socioeconomic status and working. So I think I'm maybe running out of time, am I? So what I want to do is I want to point out that there is something really important here, is that the dynamics of the infection here in the US and globally has strongly reflected disparities in the population, socioeconomic disparities, racial disparities, and demographic differences. This is a county level map of the US where we're looking at the distribution of the population, the intersecting risk factors that are age, population over 70, and households under the poverty line. And you can split this up in multiple ways. But the interesting thing here and the important thing for policy is that we've seen the dynamics of the epidemic reflecting social disparities rather than, which means that the models, there's deviation from the models because of the way that our health system is set up and the inherent inequalities in our society. And that has really changed the dynamics themselves. So that's really important for the models to grapple with and try and understand how these social and racial disparities intersect with the assumptions of our models. So I'm just going to end by saying this. I think maybe for this group, it's interesting to understand how science is intersecting with decision making and how that's changed over the course of this pandemic. And I think it's really interesting, Maya's analysis of the Trump statements and then what people are searching for. You know, we've seen the use of models in policymaking, and we as scientists like to think that this is how this works. We make a model based on all the data. There's a ton of uncertainty, a distribution of outcomes, and we give that to policymakers and say, you decide what you're going to do with this, taking into account all of the economic and social decisions. What has been happening, in my opinion, is rather that we present an uncertainty and we present science potentially, and the policymaker has in some cases already decided what they're going to do, because they are not actually, they're making decisions based on political and other motivations. They choose the models that seem to fit what they want to do, and then they call it evidence-based policy. And I think this is an interesting time for scientists as they interact with policymakers, and important to think about when we even think about the use of models to inform the epidemic. So I will stop there. Thank you.
Thanks so much, Professor Buckee, and to all of our three speakers. This has been a really remarkable set of presentations, and strikes me has several issues, some of which come up in Professor Buckee's last slide, which is this traditional assumption, and I know this as a historian of science, is that we produce the best data that we can, and then the public and policymakers will utilize that data in ways that result in better public health and medical outcomes. But given the variability in models and assumptions, it's been easy in this highly politicized pandemic for people to find in different models the public policy that they want to advocate. And I guess one place where I've seen this a lot is in debates about herd immunity. It seemed from several of the presentations that obviously getting to herd immunity is ultimately a goal for reducing or ending a pandemic. But as I've sort of observed, you know, so many of the interventions are a resistance to herd immunity in a sense, because they say we can't get to herd immunity unless we let people become infected. And I guess this is what informed in some ways the judgment in Sweden. But if we have social distancing and masks, we actually slow the process until there are medical interventions for herd immunity. But I guess what I'm asking is, when you do this work, what are the strategies for making modeling and demonstrating these characteristics of the pandemic most useful in a way that it will propel good policies, as opposed to just being seized on by a variety of political or cultural interests?
So I actually have thought a lot about this. And I completely echo what Caroline said about, you know, sort of decision-based evidence rather than evidence-based decisions. And I think that we have to be very careful. One of the things we have seen through through climate modeling has been a tendency for any uncertainty or variation in the outcome of models to be interpreted as scientific uncertainty. And that's one of the reasons why, all the way back to the start of this, what should be driving us is not the specific results of a model, you know, which may make some assumptions. We didn't talk about the difference between statistical and mechanistic models, but one of the most, frankly, dangerous things about the early IHME models was that they were making the assumption that things would go up and then go down again like they did in Wuhan, without recognizing that things went down in Wuhan because of things that humans were doing, and that would not necessarily apply elsewhere. So instead, we looked at Wuhan, and we can see, regardless of the actual underlying question of how many are asymptomatic, whatever herd immunity there is, etc., blah, 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 we can see that 2 new hospitals had to be built to deal with the threat to healthcare. So you know already that this is something that, without any mitigation, is going to cause a threat to healthcare. And when I say threat to healthcare, You know, I know that there have been hospital networks in New York in the spring where every single ICU bed was occupied with a pandemic patient. So good luck if you have a heart attack under those circumstances. Now, in contrast, so our interventions are designed to try and prevent that. Once that has been prevented, we need to think about other things. And when it comes to issues like herd immunity, I want to point out to people in this area, the suburbs that were hit hardest in Boston back in the spring, they're the northern ones, it's Chelsea, Everett, Revere. Now, those are the places where transmission is still going on. They're the ones which light up red on the state dashboard. So as you can see, no matter what happened there, we are not at that level of herd immunity now. What you want to do, and also, like I said, if you attain herd immunity in an uncontrolled way, you have all of that downslope to go through. And so we have this tremendously difficult thing handling this. We have unfortunately had a really poor level of discussion about the pandemic, driven by silly things about reopening, as opposed to frank discussions of pandemic management, deciding what amount of transmission we are going to accept with those consequences, and then how we're going to achieve it. And I'll just shut up now and let other people who know more than me say some things.
This is so interesting because we have a tendency in policy to say, well, we're open or we're closed. And these kinds of dichotomies are make good policies incredibly difficult. And, as I think all of your presentations showed, the micro locality of the pandemic is variable too, but we mostly see kind of national data in which so many heterogeneous places are integrated into some single chart. Ingrid, let me turn it over to you for a question, and then we'll open it up for the students.
Yeah, thank you so much to all of our speakers. And we have some fantastic questions from students, so I want to give them adequate time, but maybe even as we're bringing on a student, I would love if someone wanted to comment on, as you discussed, Professor Hanage, the role of modeling was so critical early on, and different policymakers and politicians seized upon that in different ways, as was alluded to by Professor Buckee. I'm really intrigued by your thoughts as we move through this time, where we have a lot more data now than we did 6 months ago, but as you said, Professor Hanage, we still have a lot of open questions. And in the realm of making assumptions, as is inherent in models, what do you see moving forward, let's say over the next few months, are going to be the critical roles that your data, all three of you, can be playing during this time, recognizing there's still all of the political machinations, shall we say, as we move through this period. But anyone can feel free to pick up, and maybe Yvonne can also bring in a student as you're answering.
Personally, I think one of the most important things about modeling will be figuring out how best to deploy any vaccine that we get, which will be useful.